Good afternoon, everyone, and I want to welcome you to the leadership webinar, Understanding the Ecosystem Overview of Ontario's Healthcare System. My name is Janine Hopkins. I'm a principal at Santis Health, and I'll be presenting this session today along with my colleague Dan Carbon, who's also a principal at Santis Health, and we're delighted you could join us today. This is the first of 2 webinars this month, and it's really designed specifically for leaders in the mental health and addictions, primary care and community and home care sectors. And this series is unique in a number of ways, but first of all, because it's a collaboration among 5 associations that represent these sectors, namely Addictions and Mental Health Ontario, the Canadian Mental Health Association, Ontario Community Support Association, the Association of Ontario Health Centres, and the Association of the Family Health Teams of Ontario. To allow for a high number of participants, we are holding the same webinar for each sector today. So there was a webinar for the OCSA members this morning. This one is for the CMHA and AMHO members, and there's one later on today for the AOHC and AFDO members. In a moment, we're going to have 2 of the CEOs of your associations, namely Camille Quenville of the CMHA and Gail Zukar of AMHO. They're going to provide some remarks. And I want to thank all of the CEOs of each of the associations for their leadership in this initiative, and the many staff of the associations and their member organizations who really provided invaluable guidance as we planned these webinars. So I'm just going to take a few moments now to go over the purpose of this webinar. Really, the first webinar is meant to provide an overview of the health policy and health system environment in Canada and Ontario. As leaders, you're responsible for steering your organization through a very complex and ever-changing system. So really, we're hoping this is an opportunity for everyone to take a step back and to understand your environment a bit better. We're hoping to accomplish 4 main things today. The first one is to educate you on the relevant aspects of the healthcare system, health policy, and the trends you should be paying attention to. We hope that you get a better understanding of what this means to your organizations and your sectors specifically. We want to impart some practical ideas that will help you interpret change and steer your organizations. And finally, we want to highlight the ways in which your sector and you as leaders can take leadership during a time of uncertain change. So no doubt you're thinking a lot about the role of government in healthcare these days, because we're heading into a provincial election and there'll soon be municipal elections. So the presentation discussion is obviously mindful of the unique context we're in right now, but at the same time, we designed the webinars so that they will continue to be relevant over time, regardless of any shifts in government and policy, because as all of you know, change in healthcare never stops. So before I introduce the 2 CEOs, I want to briefly go over the agenda and the logistics for the webinar. So we designed the agenda so that there's a mix of presentation and discussion throughout. We don't want to spend the whole time talking. We really do want to provide the opportunity for you to ask questions and hear from each other. In total, we're together for 90 minutes. And following the intro and CEO remarks, the agenda basically has 3 sections. And each section will have a presentation followed by 10 minutes of Q&A and discussion. The first section is the Canadian health system, a macro view. The second is a focus on Ontario's healthcare system. And the third looks at how this impacts the operating reality for each of your sectors. I want to emphasize again that webinar 1 is really meant to provide a broad overview of the main features of our healthcare system and policymaking. There will be an opportunity for you to get into specific questions about your sector or the areas which you operate in the Q&A. And we hope that you do join us for the second webinar, which is on April 26th, because this will really build on what you hear today and really will take a close look at Ontario's policy and political dynamics and some of the health reforms that you're aware of, such as integration, in greater depth. Before moving on to the agenda, I just want to go through a few logistical things about the webinar today. If you have any issues with technical issues, audio issues, please call Citrix, and I'm going to say the number, but this number was provided to you with the materials you received, the agenda, but it is 1-888-259-8414. That's 1-888-259-8414, and reference the webinar ID that you were provided with. If you, for some reason, don't have this number, please just send us a chat, and we'll send the number right away. We'll be using the chat feature for asking questions and making comments. So the chat option is located at the bottom of your control panel. All you do is click on the plus sign that's next to the word chat. This will expand the box and you can type in your message. You can ask questions and make comments at any time throughout the presentation, but they'll be addressed in the 10-minute or so slot following each of the sections. Scientist team members are going through all of the comments, and we're going to group the most common questions and comments and respond to them at the end of the section. We'll do our best to answer as many as we can. Undoubtedly, we will not be able to get to all of them, but rest assured, we are recording the session, we're collecting all of the questions, and the associations will save the questions and put out a Q&A following the webinars. Also, I want to point out that after the last section of our presentation, Your Operating Reality, you'll be given the opportunity to share your experiences related to the questions that we pre-circulated. So we're going to send through chat the question that we want you to think about, but think about it throughout the presentation. But really, we do want to give you an opportunity to share your observations and experiences related to that question. So the webinar is going to be available through all the association's websites, so you can look at it and share it with your staff after. And so now it is my pleasure to ask Camille Quenneville to start off, followed by Gail Zukar to provide some opening remarks.
Hi, and thank you so much for that great introduction to the webinar and to what we're trying to do here, Janine. I'm going to apologize in advance if there's background noise. I am off-site. So I will be brief and just say thank you to everyone for participating today. Thank you so much for your interest in leadership and all that it has to offer. We are extremely excited about this program, and Gail and I really genuinely believe in the value of what this will offer to our sector and our future leaders. I'll just say to you that I think that when I consider how we got to this point, it really started several years ago when we were part of the conversation around the Excellent Care for All Act and what that act meant for community generally. As we know, it was really focused on hospitals, but it gave community an opportunity to step up and say, us too, we want to be part of quality improvement conversations. We want to be part of processes that help move us forward. As much as hospitals are accountable, we want to be accountable as well. And through those conversations, we have developed new and innovative thinking, I would say, around what that means for our staff and our future leaders. And this is a really big part of that. So before it gets too loud where I am, I'm going to hand it off to Gail and thank all of you again for your participation today.
Thank you. Thanks, Camille. That was great. So I totally agree with Camille that this is an extremely important program, and I'm very excited about the opportunities that we're creating here for the community to develop its own leadership. This is something that's been missing for a long time, and I'm really excited that we have come together with key partners in the community to do this. I wanted to spend a couple minutes just talking about why I, as a senior leader in the field, in terms of years at least, believe that this kind of system knowledge is so important to you as a leader. The LEADS program that you're going to take is going to teach you a lot about how to achieve change and lead your organization to provide improved services for clients and their families. But leaders always are acting within the broader context of political and bureaucratic systems. And you as a leader will be more effective if you can help to formulate the agenda, help to set the agenda and drive it instead of just responding to what comes out. And I have to say, in the last few years that I've been here at AMHO, I've learned a lot more about just how much government and political decision makers, how much they need help from us as the experts in the community. And so I really see these sessions as being about helping our leaders to play that really key role. You know, we work overtime, you all work overtime to support your services and get attention for your clients and families. They're typically underrepresented in society and overrepresented in systems like justice, corrections, social assistance, and so on. And the community sector has not been as good, as Camille mentioned, as some of the others at really moving ahead on this larger agenda. We can talk about the stigma of mental illness and addiction and dementia, other conditions like that, but we all know that we make more progress by being proactive and respected advocates than by being victims. Hospitals and doctors have typically dominated the policy making in Ontario's health system, and we see that in the funding priorities, where hospitals, physicians, and drugs, and now to some extent long-term care, are by far the top priorities of funding in the health budget, taking well over 80%, probably 90%. You'll probably hear more about that. Janine will have more numbers. But the social determinants that we all know are so important for our clients in the community, despite the evidence about how important they are and how much they contribute to people's recovery and ability to stay well, just don't get the attention that they deserve. Certainly, it's been my observation that health system leaders, like our deputy ministers, and so on, respect other leaders who are up to date on knowledge about the health system generally. And by respect, I mean they give you their time and attention, and they put you at the important tables to help to set that agenda. So I think it's really important to have some knowledge. Doesn't have to be extensive, but some knowledge about Ontario's and Canada's place in the world of healthcare, which Ontario is not doing as well as it sometimes likes to talk about itself as. And if you can put your clients in that larger picture, it's very helpful in terms of the advocacy. I'll just say one more word, and that's about the importance of the political system. Janine referred to the fact that, you know, we've got an election coming, and if you're an AMHO member, and I'm sure if you're a CMHA member, you're getting a lot of information from us asking you to please meet with your local MPPs and candidates and get the message out. I think in the healthcare system, those of us who have come through the healthcare system sometimes think politics is a subject we don't want to deal with. But that would be a big mistake, because in Canada, our health system is a matter of federal, provincial, and local politics, just as much as expertise and knowledge around treatment and prevention and so on. So how politicians understand and regard the health system and health providers is extremely important in determining those priorities for funding for programs and research. So I think that as leaders in the system, it's our responsibility to our clients and to the public to help them understand it and be able to base their opinions and their decisions on knowledge about the clients, their needs, and the providers, rather than, you know, their own personal experience or the stories they hear in their constituency offices or at events that they attend. So this is really just meant to help you take that place and feel comfortable and knowledgeable about these things that I think are extremely important for leaders. So I'm going to turn it back to Janine, and thank you for your attention, and I'm going to listen with avid interest myself.
Thank you very much, Camille and Gail. And I'm actually going to pass it over to my colleague, Dan Carbon, who's going to take us through the first section. So over to you, Dan.
Thanks, Janine. And that was really great context from Camille, Gail, and Janine that sets up not just today's webinar, but I think the whole series of webinars and education activity in the leadership series. I'm going to start off by talking or providing a macro level introduction to some of the key features that characterize the Canadian healthcare system. And you may be wondering, you know, how a 50,000-foot overview of the healthcare system that really touches on the complex history over the past 150 years is relevant to you on a daily basis. And I think the argument that we're making, and the argument that your association leadership is making, is that the dynamics and challenges that you, the association and your sector, deal with every day, you know, which includes the continuing centrality of physicians and hospitals in the healthcare system, which Gail referenced, the kind of unclear or uneven coverage across the province for the services that you provide that might vary community to community or even within LHINs, the relatively low levels of investment in preventative services, and the high levels of private pay for many of the clients that you serve in facing, you know, mental health and addiction services, but also dental services, drugs, and other services. Many of these dynamics can be traced back directly to the political discussions and decisions that our provincial and federal governments have made over the past 150 years. And it's our belief that by understanding how all of these pieces kind of fit together, come together at the macro level, and understanding how the system has evolved, all of you as leaders are better positioned to drive forward the changes that we need to address the challenges that those reliant on our healthcare system are facing. So if you kind of take a step back and look at the Canadian system from this 50,000 foot level, and I was born in the UK and grew up in part in Vermont in the US before coming to Canada. So I've seen very different health systems up close, and all of the health systems in the OECD and across all of the countries in the world for that matter are organized around slightly different value sets, different organizational principles and what they prioritize, and how they actually kind of function. These are 5 of the things that, from the perspective of someone outside of Canada, that they probably point to and think are really kind of fundamentally different about the Canadian system, and and how these 5 factors come together. First thing to note is, as everyone's aware, Canada has a federal system of government. And what this means in healthcare is that there are different responsibilities for the provincial and federal governments. And while provinces have clear responsibility for organizing, funding, and overseeing the delivery of healthcare services, the federal government has a huge role on the fiscal side in collecting tax revenues and then dispersing them back to the provinces to pay for important social services, including healthcare. What this means in healthcare in particular is that the federal government generally collects tax revenues, and you'll probably notice on a lot of your own pay slips that the federal government collects quite a bit more in income tax than the provincial government does. And then it gives a good chunk of that back to the provinces in exchange for their agreement of about meeting minimum standards for the delivery of service across the country. And this kind of federal-provincial dynamic in healthcare has really evolved over the past 151 years, I guess now, of Canada's existence, with the Health Accord negotiations just being the most recent example. The second kind of key feature is that Canada, uniquely in the OECD, uniquely in the kind of developed world, has a universal single-tier system for physician and hospital services, where 100% of medically necessary physician and hospital services are provided free at the point of care with no copay, and no second tier where people are able to kind of opt out and access a private pay model for physician and hospital services. But the flip side of this universal coverage for physician and hospital services is that there's actually a very high degree of private pay for a whole host of other services. And we'll get into more detail on that later. The fourth factor, which is really tied to the reality that Canada has a federal system, is that provinces and territories have a huge degree of latitude to design, organize, and fund their healthcare systems, particularly outside of physician and hospital services. So it's probably a fallacy to say we have a Canadian healthcare system. What you probably have is 13 distinct provincial and territorial systems that share some attributes, especially around how physician and hospital services are covered. And how does this all kind of come together? Well, in comparison to our OECD peers, and this is kind of the Canadian health paradox, is we have really strong performance in self-reported health status, satisfaction with the healthcare system, life expectancy, and premature mortality, which is, what percentage of the population dies before 75 or makes it to old age. But we actually, despite that, or notwithstanding that very strong kind of outcomes perspective of the health status of Canadians in general, our health system performance itself, according to international benchmarks, is remarkably mediocre. And this isn't a criticism of health service providers. It's not a criticism of the hardworking professionals that work in the system. But what report after report tends to suggest is that equity and access to care in Canada, timeliness of service is very poor compared to our peers. And where things particularly seem to fall apart is in disease management for complex patients across many different providers in the care system. And that would come as no shock to you who work every day in the mental health and addiction space. So the next slide here, the timeline of key healthcare events, is our effort to distill 150 years of complex history into a few bullet points in 5 minutes So we're obviously going to skate over some of these things, but hopefully draw out some of the key trends and dynamics that really are relevant to you. And the first thing to note is that, of course, the passage of the British North America Act in 1867, which created Canada as an independent country and became the constitution for the new country, gave provinces exclusive authority over what was written in the act was hospitals and asylums. The courts have subsequently interpreted that as meaning broader constitutional responsibility for the oversight and delivery of health services. And although the federal government has no formal constitutional role for most Canadians in delivery of healthcare under this framework, it does have broad fiscal powers. And those fiscal powers essentially give the federal government a backdoor into healthcare by being able to provide fiscal resources to the provinces. And this federal role was exercised as early as 1940 when the federal government started to provide transfers to the provinces to fund new hospital construction and new beds. At that time, though, there was still no broad-based coverage at all for essential healthcare services. And Saskatchewan started to change that dynamic under Tommy Douglas's leadership and introduced coverage for full public coverage for hospital-based services. Saskatchewan's success at that time led a number of other provinces to follow suit, and essentially the federal government stepped in and said to provinces across the country, okay, we'll provide funding to ensure that there can be across Canada public coverage for hospital services. And Saskatchewan said, thank you very much. They've been funding the hospital services 100% on their own out of their provincial tax revenues. They took the additional money that the feds provided and used that to kind of spearhead the next stage in the evolution of Canadian healthcare, public healthcare, which was a medical insurance plan to cover physician services in addition to hospital services. And although that change was tremendously contentious amongst the OMA, and you still hear from a number of physicians who don't like the fact that they're under a public health plan and can't charge privately for medically necessary services, the plan, even though the NDP in Saskatchewan lost the next election, that change was incredibly popular and spread across other provinces. And ultimately in 1966 was enshrined as a core principle, as a national standard when the federal government agreed to provide matching funds to all provinces who would offer universal and physician services. And the kind of deal that was made at the founding of Medicare, if you will, was that the federal government would provide 50 cents on the dollar for eligible services. It was a shared endeavor between the provinces and the federal government to ensure that all Canadians had universal access to hospital and physician services. And that was really the deal until 1977 when Pierre Trudeau changed the 50-50 arrangement and created the Established Programs Financing Act. And this was in part a recognition of the fact that the healthcare system had evolved by that time. It wasn't just about hospitals and docs, if it ever was. Community services became much more prevalent. Home care services. These were recognized as core essential elements of the provincial healthcare systems that provinces needed to invest in. And the federal government, under the previous policies, was not providing funding for this. So they changed basically the approach to federal funding, moved away from a commitment to cost sharing, and instead instituted a health. It's gone through various names and iterations, but essentially a health transfer to the provinces. The Canada Health Act in 1984. Many people confuse the Canada Health Act with the Canadian healthcare system, or think that it dictates how the system operates across the country, or that it's the national people kind of mix it up with the Canadian national healthcare system. But despite the lofty rhetoric in the Canada Health Act, what the legislation does itself is actually much more prosaic. What it really does is it sets out the conditions that all provinces must adhere to if they want to receive federal transfers for health services. Theoretically, it's possible for provinces to opt out if they don't take the federal money, although none has been willing to do that and fund it on their own. The Canada Health Act has 5 principles that the provinces must adhere to. Public administration over the provincial insurance scheme for medically necessary services, comprehensiveness, that it must cover all medically necessary physician and hospital services, universality, that everyone is covered, portability, that if you need coverage in another province, it will be covered, and accessibility, which is that you can actually access the services, medically necessary services, and that they're provided free at the point of pay. What's missing from all this, of course, as you folks know all too well, is that the definition of medically necessary focuses on hospital and physician services. Community mental health services, home care, drugs, a whole range of other services are left out of this kind of framework that provinces have to comply with in order to get access to federal funding. There's also no reference in the Canada Health Act to equity, which is often discussed as the missing sixth principle of the Canada Health Act. Now, since that time, the only two things I want to point out are in 2004 and 2017, the two health accords, which basically signaled a trend towards greater tying of federal funding to specific activity by the provinces. So in 2004, the feds put a huge chunk of money aside and said the provinces could access it only if they put programs in place to improve wait times and transform primary care. And there was some money aside for e-health and some other investments. In the 2017 discussions, a good chunk of the money was specifically directed to targeted investment in home and community care and, as your sector would know, mental health. So to summarize kind of how all this fits together, the federal government has primarily, for most Canadians, its role in the healthcare system is to provide funding transfers that allows supports service delivery in provinces and territories, and it implements national standards articulated in the Canada Health Act for the transfer of those funds. The federal government also has a specific role for service delivery to certain discrete populations, including First Nations, Inuit, and Canadian forces. And it has other functions such as regulating products, research, and health promotion and prevention. The provinces, on the other hand, as noted, are responsible almost entirely for the management, organization of healthcare services, administering the health insurance plan within the Canada Health framework, and overseeing all of the activity of municipalities. The municipal role varies quite a lot across the country, and because municipalities are essentially creatures of the province, they don't have a constitutional role on their own. Those powers are spelled out in provincial legislation and devolved to municipalities. So here in Ontario, the municipalities play a key role in areas like public health and ambulance delivery, but also play a key role in funding a lot of community support services, some mental health services, some supportive housing services. So many organizations will receive a funding stream from the municipality in addition to the province. This slide really kind of tries to put in context the evolving provincial and federal dynamics. And if you think about it, really who pays the bills matters in terms of who gets a say in decision making. And when the federal government moved away from a 50-50 cost sharing model and moved towards block funding or health transfers, and then basically turned the taps off in providing support to the provinces, you saw their funding drop to a low of 14% in 1998-99. This was really the low point of federal involvement in the health system, where the federal government was paying less than 15% of total public healthcare expenditure. Since then, there's been pretty significant reinvestment, as we've talked about through the two health accords, which has given the feds a little more relevance and a little bit more say, but still, the vast majority of decisions are made at the provincial level, and over the past 20 years or so, you've seen quite a fragmentation and deviation in how provinces have attempted to address some of the challenges that they've been facing. Canada, it's kind of a surprise to people outside Canada to learn that Canada doesn't have 100% publicly paid healthcare system. And even many Canadians don't fully recognize this, that our level of private pay in Canada, for broadly considered, is higher than many the OECD average. And what's kind of shocking about this is 15 cents of every dollar on healthcare is paid for people out of pocket. And if you look at the chart on the right, although hospitals and physicians are almost 100% paid for by the public pay, other professionals, which would include dentists, optometrists, and others, is private pay. And what's lumped together is other institutions and healthcare spending, which would include, mental health and addiction services, community supports, long-term care, things like that. You've got between 25 and 30% private pay, so a hugely significant private sector or private insurance component to those non-physician, non-hospital services. And this chart just shows that in comparison to some of our OECD peers. Okay, the next chart, the next slide, really kind of, again, puts us in context on a macro spending perspective, including public and private pay, against our peers. And although Canada looks great, as always, on healthcare compared to the US, which spends a whopping 17% of its GDP on healthcare, we're actually slightly above the OECD average. We spend 10.5% of our GDP on health services, which is well above that OECD average of 8.9%. So if you look at how this overall spending breaks down, the public and private spending, and I think Gail referenced this earlier, it's slightly different from the public sector, but if you include the private sector, which disproportionately will cover a lot of these other professionals like vision care and dental services and stuff, the total expenditure of $240 billion, you've still got about 60% of that public and private covered just hospitals, drugs, and physician services. So those are the big three that often suck up so much time and attention from policymakers, and in part it's because they're so hugely important in terms of the budgets that are overseen by the provincial ministries of health. So in terms of how we perform, and I referenced this earlier, you've got this strange paradox where Canadians are generally really, really happy about their healthcare system. And maybe this is because, some of them have the misfortune of watching Fox News sometimes or media from the States, and they see the horror stories and the divisive debates about the healthcare system in the US, and think about how much better our system is and that people don't have to worry about going bankrupt for receiving medically necessary, at least physician and hospital care. Our satisfaction rate's about 10% above the OECD average. Yet within that, access for timeliness of care, we report the longest wait times, the worst access across the OECD, with 1 in 5 Canadians waiting over a week to get in to see their family practitioner, waiting a long time in the emergency room, and especially waiting to see specialists and to get elective care. On the next slide, this is a chart from the Commonwealth Fund, which compares the performance of countries across the OECD and looks at what they do well and where they need and how they stack up against their peers. And there's a lot of criticism on the Commonwealth Fund methodology, as you might expect from folks in the US and Canada. And in part, that's because we don't do very well according to this scorecard. Canada ranks 10th out of 11 on the when you combine all of the measures together. And what really where we really trip up, I guess, is in the area of access. Timeliness of care, people having to wait a long time, as I mentioned. But also, what was surprising to me when I looked at this was equity. That Canada is 9th out of 11 in terms of health equity. And a lot of this has to do with the fact that so many services are privately covered, and there's uneven distribution and access to those services across Canada for the non-physician, non-hospital-based services. The next slide, this kind of takes it not looking at healthcare performance as much as health status. And this is where things are interesting because Canada does a lot better on this. Our life expectancy, we get a solid B there, but self-reported health status, which is really important, we get an A. In premature mortality, we get an A compared to our peers. And if you drill down on this and you look at it on the provincial level, and as we talked about, there are really 13 different systems in Canada, and that national number is a wrap up of them all. Ontario in particular, and also BC, are kind of standing head and shoulders above our peer provinces in terms of the health status of our population, the life expectancy, the premature mortality, and the self-reported health status. If Ontario were stripped out of this national number and compared with our other countries, we would be one of the top performing jurisdictions by this measure in any case. So that was intended to be a very quick and dirty 50,000-foot introduction to the Canadian healthcare system. We're hoping that some of you might want to ask questions for further clarification. We obviously tried to cover a lot of material in a very short period of time.
Okay, this is Janine again. And it seems we haven't received any questions yet, but we still encourage you to ask questions, and we'll get to them at the end of the next section. So I'm now going to spend the next little while talking specifically about Ontario's healthcare system a little bit more. So we do know that the interplay between the different parts of the public healthcare system in Ontario, particularly between the roles of politicians, the civil servants who work at the ministries, the LHINs, the municipalities, this can all be very confusing because it's a very complex system. And it can be hard to make sense of how decisions are made and how any one organization or sector can best influence those decisions. So we really want to make the health system a little less opaque for you. And we're hoping to give you some practical information that you can use to navigate all the various relationships that you have in the healthcare system. So in this slide, it shows that in Ontario, healthcare is government's by far largest expenditure. It counts for 42% of all the government's program spending. So every year the government sets a budget and there's a finite amount of money to spend overall. And so that means it's very challenging for any government to find new funding for healthcare. And at the same time, we all know that demand for healthcare is growing rapidly. And so it's very difficult, if not impossible, to hold the line on healthcare spending without reducing access to services and then drawing the anger from the public. And we can see this, that there's currently a lot of public angst about healthcare access, ongoing stories about long waits and overcrowding in hospitals, which are in large measure a reflection of the fact that people aren't getting access to a full continuum of services within their communities and primary care, and are ending up in institutional care in hospitals. So it's not surprising that the three political parties all have either promised to increase or implied that they will at least maintain healthcare funding if they are elected. Given the size of healthcare and how rapidly demand is rising with our aging population, there's always going to be a tension between spending on urgent healthcare needs and meeting the public's expectations while maintaining investments in other areas that we know are critically important to society, things like housing and education. So what typically happens when there is a push to increase healthcare spending is that other areas that contribute to health and well-being, the so-called social determinants of health, get squeezed in order to find funding for health services. So things like social assistance, education, housing, environment, we see spending reductions in those areas. And of course, what happens then is there are downstream impacts on people's health and increasing pressure, ironically, on the healthcare system. So the next slide, and actually next couple of slides, are really trying to make sense of who are the key roles, what are the key roles, who makes decisions in the healthcare system. So we understand there's a whole host of players that are involved in healthcare policy and process. It can be a real challenge to keep up with who the individuals are and the changing dynamics. So this slide is meant to be a simplification because we really think that it's important that you understand at least who the key figures are in any given time. But while we recognize that there's a very complex ecosystem in healthcare. So really the two most important political players are the Premier and the Minister of Health and Long-Term Care. The Premier is, of course, the leader of the elected government, and he or she is responsible for the overall government agenda and has a major influence on where healthcare fits in. The Premier is responsible for selecting cabinet ministers, including the Minister of Health, and sets the healthcare mandate based on the government's overall agenda. And usually their agenda is what they were elected to deliver. So their election platform sets out their priorities. Today, each minister receives a mandate letter from the Premier spelling out exactly what they're accountable for. So that's a document that's worth looking at because it really does set out what their priorities are in terms of implementation. And in Ontario, the Premier also has their own political staff, including a special advisor on health policy. And that's important to know because they're a key individual. And that policy advisor provides strategic oversight on healthcare and really provides direction to the minister's staff and others regarding what the priorities and preferences are of the Premier's office. Next is the Minister of Health and Long-Term Care, and of course they're the senior most political official responsible for overseeing the government's health priorities. They lead the introduction of legislation and policies on healthcare. They're the key spokesperson. They defend the government's decisions in the legislature and the media. And of course they're supported by a large ministry that provides technical support and implements the policies set by the government. The minister also has a staff, runs between 15 and 25 people depending on the minister, could be more, could be less, but the staff of the minister provide policy advice, communications, issues management support, and they work with MPPs regarding the rollout of local initiatives. The political staff can have a lot of influence on the minister's perspective, and they are a key channel to reach the minister. And the minister also is supported by a parliamentary assistant. It's another MPP who's often assigned to lead an important portfolio. So in this case, it's John Fraser, and one of the things that he leads on behalf of the government is the end-of-life work. And lastly, from a political point of view, there's the cabinet committees, and they have considerable impact on health policy. Right now, there's the Health, Education, and Social Policy Committee, and important to know who the members of that are. In terms of the non-political players, there's the Ministry of Health and Long-Term Care and the LHIN are probably the two key players, obviously. And we will get much more into how the ministry is structured and operates in webinar 2. But I want to point out that the main distinction between the political side of government and the ministry is that the ministry is nonpartisan, and they're really responsible for implementing the policies of the government of the day, whatever their political stripe. The ministry does analysis, they design options, and then they use the powers of government to execute policy and funding. And the ministry also directly operates a number of programs such as the OHIP program, and they oversee the performance of government agencies such as the LHINs and Cancer Care Ontario. There are, of course, other cabinet ministers and ministries and levels of government responsible for policies and fundings in your sector. For example, we know that mental health and addictions providers often receive dollars from Children and Youth Services for children's and youth mental health, and also from Community Safety and Correctional Services and other levels of government and ministries. So it is, we understand that it's not only the Ministry of Health, it's much more complex. And obviously, all sectors are influenced by the decisions that finance makes because they set the government's budget. So significant healthcare oversight has been now devolved to the LHINs. The LHINs have been in place since 2006, and their official role is to fund, plan, manage the performance of providers and integrate particular services. They're responsible for, among other providers, community support services, mental health and addictions, and CHCs. They don't directly fund family health teams, but it's the current government's intention that they will begin to fund family health teams at some point. However, it is important to recognize that doctors' fees are still negotiated between the ministry and the OMA, and that's not bound to change anytime soon. So that's a complexity. And of course, you know that the CCACs were merged into the LHINs last year. So now the LHINs not only oversee home and community care, they actually deliver some of these services directly. So the next few slides really zero in on the LHINs a bit more and how decisions are made between the ministry and the LHINs. So many of you are probably more familiar with the LHINs than you are with the ministry because the LHINs fund you directly, and you probably sit at a lot of tables and participate in LHIN level initiatives. But we want to spend some time explaining some of the background that's important to understand how the LHIN model works and how it's likely to evolve. So each province, as Dan was saying, has a lot of leeway to structure healthcare delivery and oversight to meet their regional needs and the government's preferences. And each province has pursued its own model of regionalized healthcare at some point, largely through creating regional health authorities. And each province has also transferred a lot of local authority to municipalities for healthcare. But the LHIN model is unique, and it was designed to be a Made in Ontario model. In fact, as many of you probably know, Ontario was the last province to regionalize. So it's a fairly new model in the scheme of things. But the main reason why our province decided to move to regionalization is that Ontario's healthcare system is very large geographically. There's a lot of diversity in terms of the communities and the populations. And it was felt that it is just too unwieldy to be managed from one head office, the government, central government at Queen's Park. The example that was used at the time LHINs were introduced is that the needs of Toronto and the makeup of the health care system in downtown Toronto, where there's a concentration of academic health sciences centers, for example, is much different than the large remote areas in the north and the rural communities that dot Ontario. So the thought was that there was a need to empower providers and stakeholders within local geographic areas so that they could have a greater voice and greater accountability for coordinating health services for their populations. So it was a mechanism to really create more integrated delivery on the ground. It's important to know that the LHINs are responsible for planning, funding, and performance for about half of the healthcare service, maybe just a little over half of healthcare services, and the rest are largely still overseen and managed directly by the province. The ministry is still responsible for the Ontario Drug Plan, the insurance plan that pays for physicians and labs and other things, family health teams, and provincial programs such as Cancer Care Ontario. Both the ministry and municipalities fund public health. And it's also worth noting that although funding for long-term care flows through the LHINs, the ministry have a large role in regulating long-term care. So as many of you know, in your day-to-day work, having so many funders is challenging for all providers, and it can lead to fragmentation. So I'm just going to talk a little bit about what was the intended goal when the LHINs were created a little bit more. There were really three goals that the LHINs had in mind. The first one was devolving authorities to the local level. By doing that together providers and the LHINs would be able to come up with more tailored and relevant solutions that would, in essence, reduce the gaps and inequities that we have in our healthcare system. And as we see how we stack up against other countries, equity remains a big problem. For LHINs with large and growing immigrant populations, like say Central LHIN, they are looking at strategies to increase access to culturally responsive services. And other areas like the Northwest, their focus is on harnessing virtual care and other ways to connect communities with specialist services and reduce travel burden. The second goal in terms of the LHIN was better coordination. So the LHINs are to provide a platform for organizations to work together to coordinate their services for their population within a given geographic area. And of course, the LHINs, in their name, they have a mandate to integrate services in collaboration with service providers as a way to achieve a more coordinated experience and less fragmentation. And the third goal was to allow better management of resources. So as oversight bodies, the LHINs are accountable to the residents in their area, but also LHIN boards are appointed by cabinet and accountable to the minister, and through the minister to the public at large. So it was felt that through mechanisms like having one integrated health plan for a given area, through accountability agreements that the LHINs have, that the LHINs together with providers would be able to better allocate and use resources to improve the health of their local communities. And I want to emphasize one unique aspect of the LHIN model that's really different from other provinces, in that in Ontario, providers have maintained independent boards. So other provinces that have regionalized actually dissolved provider boards. And so all providers, all agencies, hospitals, and so on became part of a regional health authority under a single board. There are different views about the road that Ontario has gone down. One of the strengths that's pointed out is that the maintenance of boards means that we have strong community involvement and better fundraising abilities. But one of the criticisms that you'll hear is that the system is overly complex. And with so many individual boards, there's often competition over collaboration. So this next slide, we're going to look specifically at what the LHINs are responsible for. So collectively, they manage almost 2,000 health service provider funding agreements and allocate over $25 billion, or just over 50% of healthcare spending. So it's interesting to note that when LHINs were originally planned, they were expected to actually be responsible for 2/3 of the expenditures in health, but that hasn't really shifted too much. Next slide. So the point of this next slide, 29, is to reinforce the idea that while 14 LHINs have the they have consistent legislation, they have the same mandate. There's really a lot of variability in the number and distribution of agencies between the LHINs, really based on history and also their geography and the number of people that they serve. Not surprisingly, a lot of the LHIN's time and energy is spent on creating common goals for all providers to align against and really trying to enable better collaboration and care coordination. And their central challenge is really trying to get all the parts of our varied system connected and moving in a single direction. So as I was pointing out, the LHINs are in their 12th year, which is very young in comparison to other regional systems across Canada. So it's important to keep that in mind when you think about where the LHINs are in their maturity. And they also are, there is criticism about there being too much variability between the LHINs, but by design, they're supposed to be responsive to their local communities. But it's always a tricky balance, being responsive to local needs and context while ensuring that there's not too much inequity or different standards and outcomes between different parts of the province. And it's fair to say that this is this kind of tension has been faced by every single province that's regionalized. And it's no wonder that the provinces have tended to shift between devolving services locally and centralizing planning and oversight. For example, Alberta used to have a number of very strong regional health authorities. They were held up as kind of the model regional health authority model, but they really went to then one single provincial health authority seemingly overnight, the Alberta Health Services, and have remained that way for really most of the last decade. BC has a number of regional health authorities that are responsible for delivering local health services, but they also have a provincial health services authority that's responsible for planning and coordinating the province and delivering the province-wide services such as cancer care, the very specialized services. Another feature in contrast to these other provinces that have kind of gone between regionalization and centralization is that with the exception of home and community care services that were previously provided by the CCACs, LHINs don't deliver healthcare services. That was a deliberate part of the design. Now we're at a point where there's a lot of different views about whether the LHINs have enough authority or whether they've been able to fully use their mandate to have the intended impact on the system. But all the signals now are that Ontario will continue with regionalized healthcare, or devolving, possibly even devolving healthcare down to a more local level. Of course, Patients First, which is the current government's reform plan, has created subregions. Each of the LHIN has created subregions, which are really very local networks of providers that operate on an even smaller geographic area than the LHIN. So there's about roughly 5 of them in each of the LHINs. And these subregions have a responsibility for coordinating care and achieving common goals for the population in their geographic area. So it's really early days for subregions, but and it's important to point out that many providers across different sectors are already working together in their local areas and have strong relationships. So in many ways, the subregions are really formalizing and harnessing what is already working well on the ground. But both the Liberals and the PCs have supported the idea of continuing to devolve healthcare to the local level through these local networks with the LHINs, and the PCs have in the past talked about hospital-led hubs, slightly different model, and obviously it remains to be seen what exact kind of model of local healthcare comes after the election. So this is really a quote from the Auditor General's report that reflects a particular view about the LHIN's experience so far. I think it's a balanced quote, that's why we included it, but on the plus side, the Auditor General acknowledged that the provider organizations are working together more than they have even before to find solutions for common health system issues, and there's better coordination and better standardization across the system. On the other hand, the LHINs have not yet evolved to a point where they can really lead the kind of fully integrated healthcare experience for citizens across the whole province. The reality is that the way in which power dynamics work and decisions are made in healthcare is often very different than the theory, for better or worse. It just works very differently in reality, as many of you know, than it is supposed to. So the ministry has considerable oversight of the LHINs, and given the public interest in healthcare, how much there's value there is in it, there's always going to be political interest in decision making. LHINs have to be very aware of the political forces in healthcare, probably to a degree that some of the other provincial, regional health authorities do not. Because in reality, any perceived changes that impact people's jobs or power structures can lead to conflict and some kind of blowback from the public. And when that happens, obviously MPPs or ministers may get involved in decisions that were otherwise just really in the LHIN's domain. One thing for sure is that regionalization is going to continue to change. So the last couple of slides really are just a couple of real-life examples of how decisions really work in practice. This first one is a hospital example, but we think it's very germane. This is the merger between the Scarborough Hospital and the Rouge Valley Hospital that happened in recent years. And so back in 2013, there were attempts to merge these two hospitals that cover Scarborough and to create a single hospital system for the area. And there were lots of reasons why. It got as far as the two boards actually passing a motion in support of the merger, but despite their attempts, the merger discussions fell apart. And that was due in large part because of resistance from the public and from certain physicians. At the time, the Central East LHIN was actively involved in facilitating the merger, but there were a lot of political interest, as you would imagine, and local MPPs and city councillors were watching very closely. So in 2015, Minister Hoskin stepped in and created an expert panel to recommend a plan for Scarborough and West Durham hospitals. And this led to a government decision to actually merge Scarborough and Rouge Valley, and then also merge Rouge Valley's site in Ajax with Lakeridge Hospital. So at the end of the day, the LHINs were a partner, but they weren't the ultimate decision makers in that integration. This final slide is really more about headlines taken from the community and primary care sectors, but this really is to show that there's a great deal of interest, obviously, in the local level about what happens to services in communities. And the LHINs are naturally cautious about how they approach system change. Some think that some LHINs might move faster or differently on structural changes in the community sector if they had less political oversight. We know that local politicians are concerned about the optics if a provider is seen to be leaving their area, and they want to be assured that any mergers or integrations or service changes don't disrupt anything for clients and don't impact employees. So that's why it's really important to engage MPPs and municipal politicians in local decisions early and often. And these just show headlines, recent headlines, but really they show that even small changes such as a health professional leaving an organization can become a media story in the local papers. So while decision-making is increasingly being based on evidence and data, and you know, Gail was speaking about that earlier on, human and political factors will always play a role, and they may win out sometimes when there's a conflict. So that concludes this section, and now we want to open it up again for some questions, and I think we do have a question that's come in. Okay. So this is from CMHA. We're watching here together at CMHA Ontario. We have a question for one of our colleagues. We are wondering about how the policy cycle is triggered in Ontario. Should advocates be directing their attention toward political actors, the staff in the ministry, those in the LHIN, or at all three levels? Perhaps this is a broader question regarding whether policy problems are discovered in the ministry through evaluation, brought up to political actors, or whether politicians identify priorities and instruct the ministry to act. I'm going to ask Dan to step in and speak to this one first.
Sure. Thanks, Janine. Well, I think Janine actually spoke to a lot of this in her comments, and I guess the basic answer is that although that there are clear roles and responsibilities and divisions of power, I guess, between the political arm of government, the ministry, and the LHINs, in practice, the healthcare system is a complex interdependent system, and it's incredibly messy how decisions are made, and it is often described by those working within the policymaking as akin to a sausage making process. And what this means is that change can be driven from the political leadership. So you can have a minister in power, or someone working for a minister, or a premier, or an advisor to a premier, where advocacy is persuasive to them, and the minister decides that they want to act. They say, you know, just recently, say, for example, on the issue of hospital crowding, that this issue has become too pervasive in the media. I believe that we've squeezed hospitals as far as we can possibly squeeze them, and now is the time to put some more money into the budget, and then would turn to the civil service and say, you know, what is the level of investment that's required to significantly address, you know, hallway medicine or whatever it's being referred to as. At the same time, a lot of those kinds of recommendations can indeed feed up from the ministry and the LHINs, where civil servants can say, look, we're starting to notice that services are fracturing, they're falling apart, and we're hearing we don't think that we can go another year with no base increases in the community mental health sector, or there will start to be implications. And those are brought up to the political decision makers often through the annual budget cycle, where the civil service, if you will, gets the first crack at the allocation of resources in the annual business plan of the ministry and allocating how much what goes to each area. Then there's almost like a negotiation between the civil servants and the politicians about, well, can we give 2.1% to this group, and what does that mean to other sections of the ministry within the envelope that we're operating within? So although this is not an easy answer, I guess the answer is that all of these actors can and do play a key role in making decisions within the healthcare system. And on certain issues, you really need to understand the local dynamic. But in the Scarborough example that Janine referenced, although that was clearly within the purview of the LHIN, the integration of those hospitals, because of the dynamics, there was a recognition amongst the activists in that community that there was no way the LHIN could move forward with if there was opposition from the Ministry of Health and opposition from the local MPPs. And that's kind of what happened there, is that there were dynamics that were really important at the community level, and those activists got to the local MPPs and to the Ministry of Health. And so this became a process that where it wasn't entirely clear cut how the decision was being made, because there was negotiation between the different parties, notwithstanding their I guess their legislative authorities. Are there any other questions? Okay, so I'm going to take us on to the next section, which is titled Your Operating Reality, the Funding Environment and Its Impact. And you might be wondering why we're focusing so much on funding in this webinar. But the reality is that the level of funding that is provided to the system, the decision Janine talked about, and I think Gail referenced about, first of all, how much does the government allocate to health versus other social spending? And then within healthcare, what does the budget look like compared to last year? And then how are allocation decisions made between sectors? And what are the accountabilities associated with that funding? All of those decisions directly impact your day-to-day operational reality. They impact how many clients you serve, how much you can invest in infrastructure and administration versus frontline service provision. In some cases, the funding strictures of the government dictate how much you can increase the pay of your staff, or whether you can increase the pay of your staff. And there are significant implications for recruitment and retention of staff. So the funding environment, understanding the dynamics in the funding environment is incredibly important for your organizational success and the ways you operate on a daily basis. On the next slide, really go to kind of put the funding environment into context. And what all of you have been experiencing over almost the past decade now, since really starting around 2010, is a very, very tough funding environment in healthcare. In 2008, with the major recession, government revenues collapsed, and the provincial government found itself facing a $25 billion deficit. And even though they put a 10-year plan in place to get back to balance, they really built that plan around ongoing constraint in the expenditure growth of public services. And although certain services and certain ministries have had significant outright funding cuts during this period, the Ministry of Health has really been constrained in a different way, which is that it's been given essentially increases between 1% to 2% a year. That's just around the rate of inflation. This rate, though, when you add in the factors of population growth in Ontario, which is running over % a year, population aging, chronic disease incidence, and all the new treatments coming online, this level of funding is nowhere near the level of demand growth in the healthcare sector. Economist Don Drummond, I think it was in 2009, estimated that basically to keep things running the way they were at the time, if no changes were made, public spending would have to go up on average 6.5% a year to continue the same service standards. Obviously, we haven't had 6.5% funding growth a year, but there hasn't been the level of, I guess, detriment to the population. There hasn't been. You haven't seen massive reductions in access to healthcare services that you might have expected given that gap between demand and supply. And that's because both the government and service providers have really tried to come at how the healthcare system is organized, operated, and funded in a different manner. Key aspects of this have been to continue a long-term trend of pushing service delivery away from hospitals and doctors and into the community sector. And although it might not be top of mind given the announcements recently regarding significant reinvestment into hospitals, but hospital budgets were essentially flatlined until last year, and doctors have been subject to a wage freeze and cap on billings. And the small amount of growth that was available in the system was disproportionately, I guess, directed towards the home and community sector, the community mental health sector, and others that saw, although starting from a much lower base, relatively higher levels of annual increases. On the next slide, it's what we're trying to show here is that the pace of change, I guess you don't notice it on a daily basis, but these are changes that are happening over 5 years, 10 years, 15 years, 20 years, where in Ontario there has been a steady push to try and reduce the reliance on hospitals as a centerpiece of the healthcare system. Now in Ontario, it's something like 36% of public expenditure is on hospitals. That's actually significantly lower than many of our other peer jurisdictions in Canada. They'd be more kind of stuck on the left here, around 40% of expenditure. So over time, there has been a concerted effort by governments of all stripes in Ontario to try and reduce the reliance on hospital expenditure and increase services in the community where more people are reliant on care. This chart, which I think is from the Fiscal Accountability Office, it shows that between just the most recent 5 years, community sector growth, which would include a significant component of community mental health and addiction services, has run at almost double that of hospital expenditure. Of course, we're not talking about base budget increases, which many of you know have not been handed out at all or considered until the last budget cycle. But in terms of just the overall funding increases going to the sector, that if you try and look at the overall healthcare kind of funding dynamics, as I've said, what the government has tried to do is constrain funding at a time of significant growth in demand for services. And providers have essentially been forced to live within the means of a fixed budget, even though the pressures are growing on them within each year. No annual base budget increases has generally been the norm across not only community mental health, but home care, where they've dealt with a rate freeze for 10 years, primary care, where there were no increases for health professionals for a decade. So this has been a pretty consistent theme. And that funding has only been available to organizations in large part when that funding is targeted new service volumes. Also, not just volumes in many cases, though, but new volumes delivered through new care models that are informed by evidence and often at the behest of the LHIN require collaboration from across providers. So you've probably seen a lot of things recently where the LHINs will put out almost a request for proposals or identify that they've got new funding available, and some of them will explicitly require that providers get together to put in a proposal for that funding. So in terms of what these changing dynamics have meant for you as a health service provider and as a leader within the system, and you know this far more than I do in terms of the impact of this on a daily basis, but there's really been little to no base increases and limited ability to increase the salary of staff working in the sector. There was a wage freeze for several years, and since then the funding, the lack of base funding increases has really constrained the ability of providers to increase pay in line with inflation or the general wage increases in the overall economy. That's led to challenging dynamics for staff retention in a number of organizations, but it's also prompted new ways of thinking about how to serve client needs. And you've seen this almost like flourishing of innovation and entrepreneurship, and people really recognizing that in order to do more with essentially less, even though there may have been some slight nominal increases for new volume, that they've really had to think about how to meet client needs in new ways by partnering with others, by getting together and sharing back office services, or even in some cases by integrating with partners who can provide fully integrating with partners who can provide more infrastructure. Next slide. This slide really just is headlines that we pulled from various media articles over the past year or so, and it really serves to kind of shine a spotlight on your sector and show that a number of organizations and the associations have really taken a leadership role in trying to address that fragmentation of care that I talked about earlier on, the gaps between service providers to try and provide a more seamless client experience across the healthcare system. Connecting community mental health to primary care, to acute care services, to rehabilitative services, connecting community mental health and addiction services to senior services in many cases due to the aging of the population. Now, as we were preparing this webinar series, the 2018 Ontario budget landed with a bit of a thud, and there's a lot of question: does this budget mark an inflection point? Are we finally coming out of this period of prolonged healthcare austerity? Are we going to go back to those days? You might have noticed on the other chart, the last time that healthcare spending was significantly reined in the mid to late 1990s. It rebounded pretty strongly after, because you had all this pent-up demand for care. Is the government finally recognizing that organizations can be squeezed no more, and that when you're seeing wait lists increase for CCAC services, wait lists increase for surgical services, wait lists kind of across the system mounting after they've been declining through much of the early 2000s, has the system been squeezed as much as possible? Are organizations operating as efficiently as possible, and that any further cuts would really start to undermine dramatically access to care? Well, the current government seems to have reached that assessment. They're planning for almost 5% growth between 2017, 18, and 2021. And the way budgeting usually works is that those numbers are prone to increase. So you'd expect that would go up over 5% if this government was kind of returned to office. So this seems to be a kind of commitment to reinvestment in healthcare, and for many folks, it's the first time there's been a commitment, including community mental health. First time there's been a clear commitment to sustained ongoing base increases, in many cases for over 10 years. And this is made in part possible by the renewed funding in the Health Accord. But there is a lingering question, which is, if there's a change in government, would that government share the commitment, or a new government share the commitment to reinvestment in healthcare? Particularly if a government is elected on a platform of continuing to reduce public expenditures, or to reduce tax and hence revenue of government, they might not be able to afford, or think they can afford, 5% annual growth in the healthcare sector. We don't really know. As Janine said, we've got to wait for all of the party platforms to, and details around them to come out. In the NDP platform that was recently released, it does seem that they are committed, if elected, to continue this kind of an investment. I think their investment or funding expenditure profile going forward was very, very similar to what the Liberal government had committed through this budget process. But a lot of the pressures you face, even in a 5% funding environment, will not go away. There will still be that delta between hugely growing patient demand for care, aging of the population and population growth, and what the provincial government can provide. And that's why your sector really needs to continue the work that it's been doing, the work that Camille talked about, really, that where you've really switched gears and kind of upped your game especially since the Excellent Care for All strategy came out, where I think there was a recognition across the community sector leadership that this sector could play a far more assertive role in having a seat at the table in shaping the kinds of changes that are happening across the healthcare system, and that it required investment in capacity, investment in leadership, investment in infrastructure to be able to deliver the kinds of high quality services that governments are increasingly expecting and demanding in exchange for future funding. And then I guess where we're going to wrap up is to say, you as leaders at the organizational level play a key role in driving this change forward. As much as governments can have a strategy and LHINs can have a strategy, that kind of top-down approach is destined to fail if it's not complemented with bottom-up advocacy and bottom-up, almost a reality check of how things are working at the front lines. And by being part of those conversations at the LHIN level, by talking to your MPPs, by sharing your experience and advocating for better models of care for your clients, we really think we can address what the quotes here refer to, that the Change Foundation found from its engagement of lots of Ontarians across the province, which is that the difficulty people face was the understanding how to move around the system, a problem of care coordination, case management, or patient navigation. Any of these terms will do. Essentially, the cracks that still exist in our public healthcare system that really can only be filled by the work of those in the community sector working in collaboration. So thanks for your time today. We're going to turn it over to some questions now.
Hi, everyone. This is Janine. We do have a couple of questions here. The first one is, we have questions that have come in from you, but we also are going to start with actually asking if you want to weigh in on the question that we pre-circulated. So I'm just going to, we sent this out with the material, so hopefully you've had a time to think about it, but I'm going to repeat our question and hope that some of you will have some experiences or perspective to share. So some LHINs are great at establishing collaborative tables and models with stakeholder groups and service providers at the table. Which relationships can you leverage to make better funding decisions? So we encourage you to comment on that. While comments are coming in on that, we are going to address a few of the questions that have come into us. Okay. Just a moment here. Okay, the first question is, it may come as a surprise to participants that there have been many additional investments in community services, especially community mental health and addictions. Can you explain some of the reasons why many such providers have not had any increases and have to continue to pay substandard wages and lay off staff to meet service level targets? Okay, I will start. Dan saying I will start with this. So, I think I'm building on some of the things that Dan was talking about in this move toward cost containment, is that we've seen a move away from across the board base funding increases where every agency gets or every provider gets a guaranteed increase every year. This trend is not likely to change, and while the sector as a whole, or the community sectors as a whole, have seen an increase in funding, it hasn't been, these funds have been used by the LHINs really to target specific agencies or specific changes that they want to see in the system. What this means is that many organizations have not seen any increases in recent years. And the other thing to say is that while in recent years there has been an increase to the community sectors and community mental health and addiction specifically as a sector, that is really barely even compensating for the many years of zero base increases for the entire sector. So the increases that have been made are really making up for a long-standing deficit in the sectors. So that I think is the dynamic. Some agencies are seeing increases in funding because they're playing a lead role, or they're being the transfer payment agency for a particular initiative, but many agencies are not seeing really any increase in their operating funding, and certainly many are not seeing increases to keep pace with increasing demand, the complexity of the clients that you're seeing, and the increasing expectations that you have from LHINs and other funders around information that you report and the administrative requirements for funding. I don't know, Dan, do you have anything to add to that?
Just a little bit of additional, I guess, color in that. I haven't seen the analysis on this, but I bet if you drilled down on the funding that has gone to the community sector and the community mental health agencies, that a disproportionate amount of that would have gone to a smaller subset of the sector who are almost becoming seen as preferred providers in a way by the LHINs. And the LHINs have been targeting funding, as Janine mentioned, much more to organizations that are seen as having, and whether this is correct or not, they're seen as having higher levels of sophistication, infrastructure, administrative capacity, and are able to report on the impact of the funding that they've been provided. So it'd be interesting to see how it's kind of dispersed between the sector. But as Janine did note, that funding has usually been tied to new service volumes and new programs that have been offered. So it has been almost universal that organizations that haven't delivered additional new programs or new services have received no funding increase. But although that might be changing through the 2018 budget process, we'll have to keep close attention on that. I mean, I have not. Gail's probably more aware of the dynamics in the community mental health sector and how the increase to the sector might be allocated in the future if the government's reelected. But I saw something on the home and community side recently where the budget committed to a rate increase for personal support and nursing and therapy. But even there, the LHINs may have discretion to target that funding within that envelope to certain providers and for certain activities. So it's unclear as to whether all organizations will be able to get base increases in the future or across the board increases.
Okay. Has there been any comments come in on our question? I don't think so, right? Okay. So we're going to just address another question that's come in. What role does professional development and capacity building play in this funding landscape? If the expectation is for evidence-based practices to be applied, how is knowledge translation and dissemination expected to take place when there's limited or no funding for training and education? Which envelope would this be covered under? I'm going to take a crack at that. I think one of the things that certainly the LHINs have been, to varying degrees, looking at is they would see it as their role to help build capacity amongst providers, particularly the community-based and CHCs and community-based providers. The LHINs do have rather limited discretionary funding at this point. While they are responsible for allocating a lot of funding, they have very little funding that they can actually provide to providers for things like capacity building, information infrastructure, coordination, and so on. But they are using, I think, their funding in pretty creative ways to help build a capacity, and they're doing it differently in each of the LHINs. I also think that the associations themselves, and I think this initiative and the whole leadership initiative is a capacity building endeavor, that's a big part of their role is to work across the provinces to build capacity. But I guess the overall comment is that there's a critical need to have the infrastructure in place, and I think that certainly the funding and the resources is not yet at the level it needs to be. I think that Gail Zukar is also going to address this question.
Well, I think Dan and Janine have been have answered these questions spectacularly, so I don't know how much I can add. I would say that certainly this leadership initiative is a big part of answering that question about training. I would say from what I've seen, particularly given the commitment to publicly funded structured psychotherapy and the rollout of that program, that we are going to see there is a recognition, certainly in the ministry at the staff level, that there needs to be a significant investment in training and professional development in this sector in order to meet the need. Some of you will know that in our pre-budget and election platform, we're asking for 550 new FTEs, new positions per year for staff for 4 years. And we keep being asked by the politicians we meet with, do we have that capacity? Are people there? Are people ready to do this? If we say we're going to do it, are you going to have the people ready? So there is a recognition that that's needed, and certainly the investment in this program indicates the belief in that. So I think there's recognition, and the fact that we did get on the map in the budget, and with the announcement says that the government realizes at staff levels, and I think increasingly at political levels, that there needs to be significant investment in this sector. So I feel somewhat optimistic about that, depending again on the results of the election in June. Could I comment on your question about working together? Maybe I can kick something off here, that your question about, LHINs being good at putting people together.
Yep, please.
I would just say that, having been around this field a long time, as many I'm sure on the phone have been, I think my perception is that in the earlier days of the LHINs, and even before the LHINs, when the ministry was funding the system directly, there was more emphasis on collaborative work and joint proposals and so on than there is now. I would say what's changed in the last few years is the expectation of collaboration across sectors. But I think the experience of many of our members in the last few years is that LHINs are increasingly likely to do what's popularly called shoulder tapping and picking an agency and saying, okay, we're going to give you the money, you develop this program. This is what we need. LHINs are some are feeling a little more confident about saying, this is what we need in community mental health or addictions. We want somebody to do this, you do it. Or in other cases, they've actually tapped agencies and said, we're going to give you the money for the whole program. You figure out and you collaborate and you have agreements. Effectively implementing a lead agency model without calling it that. There's been very few of those. But I think I would say, it used to be in the 90s that we saw more tables of mental health and addiction providers doing collaborative planning and so on. Today, I think certainly in Toronto Central LHIN, for example, the expectation is that the collaborative work will be across sectors. So it includes long-term care, community service, support services, home care, primary care, and community mental health and addictions. And, I don't know, but I'd be curious what other people see in their LHINs. I've seen fewer sector tables and a lot more kind of direction from the LHINs.
Thanks, Gail. I think, that's almost a good stage setter for the second webinar, where we are going to be getting into a little bit more deeply into, what's really happening on the ground around a lot of these directions, such as integration and where, and collaboration, how that's really playing out. So I think that's a great food for thought, I think, for sure. I think we're just looking at the time, and it seems that we've almost reached the end of the webinar. And so I want to say on behalf of Santa's Health, just really thank you for taking the time and such a great dialogue and sticking with us for an hour and a half. We hope that you got a lot out of this, and it really does answer some of your questions that you've had, and we really do hope that you join us on April the 26th so we can continue the conversation and get into these issues a little bit more. Before we wrap up, I want to pass it over to Kathleen of OCSA, who's going to go over just a couple of final housekeeping things.
Thank you, Janine. Thanks to Janine and Dan from Santis, and thank you to Camille and Gail for their really eloquent and stage-setting comments there at the beginning and throughout. Such a robust and foundational overview of the Ontario healthcare system. Like Janine said, please come back and join us next week as we get into the more in-depth understandings of how these policies are impacting you in your daily work lives. Just a reminder that an evaluation will pop up after this webinar is finished, and it will also be emailed out to you by Nicola, the project coordinator for the project. She'll be emailing you the slide deck, the recording, and the link to register for webinar 2, which is the same place where you registered for the first one. So the second one is called Making Sense of the Policies Behind Healthcare Reform. And just a note, I've put the Twitter handle for the project there in the chat box. Please follow us on Twitter to get all of the most up-to-date information regarding the project and how you can not only participate in these webinars, but also our LEADS learning series that we're implementing across the province. And stay tuned next week through your emails and through that Twitter handle and through your own association Twitter feeds and newsletter outlets for the launch of our new project website. With that being said, thank you so much for your time, and we hope to see you next week. Take care.